Welcome to the 4-Year Nursing Review. Today I'm going to be reviewing the medical surgical nursing content. I'm Professor Anthony Pennington. Before we start reviewing, I'd like to give you just a little background on my qualifications as an expert medical surgical nursing instructor. I've worked in a variety of roles as a registered nurse, including 12 years working as a bedside nurse in medical surgical nursing. I have over 14 years of teaching experience at both public and private institutions in the state of Florida. I'm certified as a nurse educator by the National League for Nursing, and I'm a member of Sigma Theta Tau International Honor Society. Currently, I'm the Dean and Program Director of a second-degree accelerated baccalaureate nursing program in Florida. Lastly, I started working with the 4-Year Nursing Review in 2013. I'm very excited to be teaching this online course, and whether you live far away from a live review course or maybe work evenings and nights, or you've been away from nursing school for a long time, you'll be fully prepared for the medical surgical portion of the NCLEX. In addition, this online video course will also help ESL nursing students and really all students who are committed to working hard to pass their program's exit exams. So let's get started with the medical surgical nursing review content. So fluids and electrolytes. When we talk about intake and output, well, what do we consider to be part of intake? So that includes anything the patient drinks, so any PO fluids. And that's the obvious thing, but there are other things that are part of input that we may not think of right away. So think of any foods that become liquids if they're left at room temperature long enough. So that includes Jell-O, ice cream. It does not include pureed foods. So sometimes people think it's the kind of consistency of a liquid, so they think that's considered a liquid, but it is not. It also includes things that we give to the patient IV. So your IV fluids, the medications, blood products, and also tube feedings. And when you're documenting intake, you want to document this in milliliters, and that's how you're going to want to record it. What's considered output? Urine, vomiting, so emesis, liquid stool, diarrhea, any drainage from a wound, whether it's in a JP or some type of a drainage container, and blood as well. You'll notice that on an OR report for surgery, it'll say how much blood was lost during that surgeries, and that's documented as milliliters. And so those are things that you want to make sure that you're documenting whenever you're looking at output. So what is the average adult urine output in 24 hours? It's a pretty wide range, but usually 800 to 2,000 milliliters per day. The average, if you're looking at it per hour, is 60 milliliters per hour, or 1,440 milliliters in a day. What's very important to understand is what is the minimal amount of urine output that's acceptable, and that's 30 milliliters per hour. So if you have a patient that is not urinating 30 milliliters per hour, that puts them at risk for kidney damage or renal failure, and so you want to report that to the physician as soon as possible. Some signs and symptoms of fluid excess: rapid weight gain. And we can equate weight to fluid retention. So we figure that 1 liter of fluid is equal to 2.2 pounds. So if your patient has gained 4.4 pounds approximately, then we might be able to conclude that they have retained 2 liters fluid. We'll see edema, such as pitting edema. We'll see pulmonary symptoms such as dyspnea, crackles when we listen to their lung sounds, or just difficulty breathing in general. As they hold on to fluid, there's more fluid in the vascular system, so their blood pressure rises, and to the point even of seeing jugular venous distension. Our treatment of excess fluid really depends upon the cause. If it's because of sodium intake, then we'll put them on a diet where they will consume less sodium. So usually it might be a 2-gram sodium diet. Remember that sodium leads to fluid retention. So by decreasing sodium, we can decrease the amount of fluid that the patient retains. Diuretics such as furosemide to help get rid of fluid. We mentioned restricting sodium also may restrict fluid intake altogether. But the key thing is to treat the underlying cause. Whatever's leading to that excess, we want to treat that. Fluid deficit or dehydration. We can see some blood pressure changes. And what would you expect to see in somebody who's dehydrated? Well, we mentioned in somebody who has fluid volume excess, their blood pressure is going to rise. So someone who has dehydration or fluid volume deficit, we would expect that their blood pressure is going to decrease. Tachycardia, heart rate races, anorexia, nausea, they can lose weight, deficit due to poor intake or due to vomiting and diarrhea. That can definitely lead to dehydration. Weakness, oliguria, so low urine output, thirst, dry mouth or dry mucous membranes, and poor skin turgor or delayed skin turgor when we're checking for that. With dehydration, the fluid intake is less than what the body needs. Consideration for older adults, dehydration is more dangerous for our patients who are older. Aging actually causes some changes in water composition within the body. Renal function tends to decline in those that are older. And also, an older individual has less perception of thirst. So they may be slightly dehydrated and they don't have that desire to drink. And so we need to be aware of that. Our older patients are much more susceptible to dehydration. Treatment of fluid deficit. Well, the obvious answer is to replace that fluid. So whether it's drinking more water, more fluids, and or administering IV fluids. Correct the cause of the dehydration. And then safety, secondary to dizziness, weakness, and postural hypotension. Patients need to be assisted getting up out of bed because if they're dehydrated, they stand up, their blood pressure will drop even further. So you want to make sure that these patients have assistance, for example, when they need to get to the restroom. A little bit about IV solutions. They kind of differ in osmolarity depending on how their solutes are concentrated and how it compares to the osmolarity of the blood, of the plasma. So you're probably familiar with normal saline, and you might have seen that normal saline is actually called 0.9% normal saline. And that's how we define normal saline, that 0.9%. So guess what half normal saline would be? And you may have seen this in clinicals as well. It's 0.45%. So our solutions that we give our patients, our IV solutions, are generally classified as either isotonic, hypotonic, or hypertonic. So what distinction there is between these can be identified as what happens to a blood cell whenever it's exposed or placed in one of these environments. So for a hypotonic solution, the red blood cell swells, and your isotonic solutions include half normal saline. So that's a prime example of hypotonic. For isotonic solutions, kind of keeps everything at the baseline. So your red blood cells really don't have a response. They're kept the same. Some common isotonic solutions are normal saline, D5W, and lactated ringers. Your hypertonic solutions, this is when your red blood cells actually shrink in size. And a common hypertonic solution is D5.5 normal saline. All right, so we're going to talk about some specific electrolytes. And NCLEX is going to want you to know what some of these normal values are. They're not going to tell you that the potassium level is 2.2, as we mentioned earlier, and that's low. You need to know that that's a low potassium level. So we're going to go over some different electrolytes. So what's the big deal about electrolytes in the first place? Well, they have many functions. They affect neuromuscular irritability. It helps to maintain the proper amount of fluid in the body, including distributing water throughout the compartments of the body, and helps to regulate acid-base balance. So they play a very important and vital role in the body altogether. So these are some major electrolytes and kind of in a nutshell what their major functions are. So first one we have is sodium, Na. That controls and regulates body fluid, so the volume of fluid that's within the body. Potassium, or K, regulates enzymes as well as water content. Calcium, nerve impulses, blood clotting, muscles, and absorption of vitamins such as B12. Magnesium metabolizes carbohydrates and proteins, as well as actions involving enzymes. Chloride maintains that osmotic pressure in the blood. Bicarb, which is the HCO3, is a primary buffer system in the body, and we're going to see more of how bicarb is involved in acid-base balance. And phosphate is involved with chemical reactions in the body that has to do with primarily cell division. Also, if you look at these electrolytes, and I was to ask you which electrolytes affect cardiac status of patients, you should know that the three that are mostly involved with cardiac issues are potassium, magnesium, and calcium. So if you have a patient that has some type of a dysrhythmia, for example, we would want to check those three electrolytes specifically. So electrolyte imbalances, we're going to start with potassium. So there you have your normal range of potassium, 135 to 145, and that's in milliequivalents per liter. We talked about how sodium is involved in water balance. Sodium is absorbed from food and then eliminated by the body, whether it's from voiding, from diaphoresis or sweating or having a bowel movement. It's the most abundant extracellular electrolyte. So think about sodium. First off, if somebody's sodium level gets low, the risk there is for seizures. So typically around 117 to 119 is when seizures are likely to happen. And I've had many patients that their sodium level is trending down towards 119, and wouldn't you know it, it gets to 119, 118, 117, and then you'll start seeing seizures. So we want to be monitoring our patients very carefully if their sodium level's low to make sure it's not getting as low as 117 to 119. The other thing about sodium is imbalances in sodium really usually have nothing to do with the amount of sodium that's in the body. It has to do with the amount of fluid that's in the body. So if somebody is overhydrated, they have excess fluid in the body, their sodium level goes down due to a dilution effect of the sodium. If someone is dehydrated and they don't have a lot of fluid in their body, then their sodium level typically rises, and that's where we get high sodium levels. So when we're looking at how to treat these patients, we don't typically treat them with sodium. We fix the fluid imbalance, and then the sodium level gets in line. So I kind of tell my students, if you think about if you have a cup of sodium and you put it in a jar of water, and you look at that concentration of sodium, you take a sip, you're going to taste that salty taste to it. But if I take that same cup of sodium and I dump it in a swimming pool, not that you would take a sip out of your swimming pool, but if you did, you would probably hardly taste any sodium at all. Even though the sodium level's the same, it's the concentration or the amount of fluid that makes the difference. The next one is potassium. Potassium is maintained by that sodium-potassium pump. And when we see changes in potassium, we see changes in our muscle activity. I mentioned the cardiac cells and neurological functions as well. Potassium is eliminated by the kidneys. So if the kidneys are not functioning properly, then you may see a retention of potassium. So you're going to see a higher potassium with patients who have renal disease. It is the chief intracellular electrolyte. And also insulin causes potassium to move out of the extracellular fluid and back into cells. So especially with skeletal muscle and liver cells. So sometimes the treatment for somebody who has too much potassium in the extracellular fluid is to administer insulin. So here you can see some of the signs and symptoms of someone who has both a potassium deficit or hypokalemia and patients who have a high level of potassium or hyperkalemia. Again, I'm not going to read each of these to you. They're here on the slide for you. I'm just going to point out some of the most important things. With hypokalemia, or that potassium deficit, a common cause is the use of diuretics. Patients who have copious amounts of diarrhea, or patients who are vomiting a lot. So you want to make sure that if you have patients, such as your patient with C. diff, and they're having a lot of diarrhea, that you are monitoring that potassium level. With high potassium levels, or hyperkalemia, common cause is renal failure, as we mentioned earlier. So the patient does not have full kidney function, and the body is not getting rid of potassium in the urine. Therefore, that potassium builds up in the blood, and we end up with hyperkalemia. We'll move on to calcium. 9 to 11 milligrams per deciliter is our normal range for calcium. And you can see the major functions. It's involved with nerve function, the heart, clotting, formation of bones, actually, and that makes sense when we think of calcium, and contraction of muscles. So it's controlled by vitamin D, parathyroid hormone, and calcitonin. So what these do, vitamin D helps the body absorb calcium. So it takes the calcium that's in the body and makes it available. The parathyroid hormone also helps with the absorption of calcium, just like vitamin D does, but it also stops the kidneys from excreting calcium, so it helps you retain the amount of calcium that's in the blood. And then calcitonin decreases blood calcium levels. Half of all calcium is in an ionic state, half is plasma bound. So it bounds to albumin, holds it into the bloodstream. So this you definitely want to know about hypocalcemia. These are two important methods that we use as nurses to assess for low calcium levels. And we have Trousseau sign and Schwastik sign. So we'll start with Trousseau sign. The way that you elicit this, as you can see in the picture here, is you place a blood pressure cuff to the upper arm, and then you inflate it above whatever that patient's systolic blood pressure has been for 3 minutes. After 3 minutes, as you can see in the picture, you will see flexion of the wrist and fingers, and that's a sign of low calcium. The other method is the Schwastik sign, which we have the picture of the gentleman's face. And with this one, you tap the patient's cheek. You're essentially tapping the facial nerve. And if you see twitching of the nose and or the lips, that's also a positive Schwastik sign, and that's also an indication of hypocalcemia. So the way that I remember these two is I think of T for tourniquet, which is what you're doing with that blood pressure cuff. You're kind of cutting off the blood supply to the hand. T for tourniquet and T for trousseaus. For Schwastik sign, I think of C for cheek, because you're tapping on the cheek. So C for cheek and C for Schwastik sign. And each of those indicate a low calcium level. All right, so we have our review question. We're caring for an elderly client who's receiving IV fluids. During the 8 a.m. assessment, the IV solution, which was ordered to infuse at 125 milliliters per hour, has infused 950 milliliters since it was hung at 4 a.m. So which of the following is the priority nursing intervention? So again, we have a question here asking us what's going to be the priority. What are we going to do first? So are we going to notify the physician, slow the rate to keep the vein open until the next bag is due, obtain a new bag of IV solution just to maintain that the site is patent? Or are we going to listen to the client's lung sounds and assess their respiratory status? Now, one way I like to look at priority questions is to use the nursing process. So if you remember, the first step of the nursing process is to assess. So we assess our patient before we do interventions for the patient. So if I look at this question, 1 is notify the physician, that's an intervention. Number 2 is slow the rate, intervention. 3, obtain a new bag of IV solution, that's an intervention. But item 4, listen to the client's lung sounds, means we're assessing our patient. And wouldn't you know it, that's the correct answer. But you need to understand that after 4 hours of infusion time, we should have infused 500 milliliters, but instead 950 has infused, so that's almost twice as fast. So now they're at risk for fluid volume excess. Even if they were admitted with dehydration, we're overhydrating them or hydrating them too quickly. So you need to assess the patient's respiratory status before you notify the physician and before you take any further action. This concludes the medical surgical nursing review content of the course. If you've completed viewing the medical surgical nursing review, you've been exposed to all the important concepts and principles that are likely to be included on the NCLEX. If you need to, go back and review your areas of weakness some more. Go through the videos, the quizzes, the study book as many times as you need. Develop a systematic program of study, as we talked about in this course, dedicating time every day to prepare for the NCLEX. Don't confuse yourself by using too many sources. And perhaps most importantly, be sure to take the NCLEX within 3 months. There's much research that clearly indicates that when an individual waits more than 3 months to take the NCLEX, their likelihood of being successful decreases significantly. For example, at the nursing program where I work, our recent graduates had a 98% pass rate for those that took the exam within 3 months. But we did have a few students that waited more than 3 months, and the pass rate for those students was 71%. So I encourage you to put as many elements in your favor as possible. You have all that you need to be successful on the NCLEX. Use the resources provided to you by Foyer Nursing Review. Use everything available to their full potential, and you can do this.